Good morning, good afternoon, and good evening. It is with great pleasure that I welcome you all here today for this webinar on imaging lymphatic disorders with optoacoustic tomography. My name is Dr. Tim Devling, the Director of Sales and Applications at Icthera Medical, and I'll be moderating this session. The webinar, will last for a little bit longer than 40 minutes today, and we really encourage questions. If you maximize the Go-To tool, you can see a question box where you can type them in and we will answer at the end. Our speaker today is Dr. Guido Giacalone, who's a medical doctor and PhD, who is the head of the Department of Lymphatic Surgery at Sint-Maarten's Hospital in Belgium. Guido has a strong track record in the improvement of lymphedema treatment, particularly using image guidance. And it was through this topic that it was he and my colleague Thomas Sardella who spent a number of hours at a recent lymphatics conference discussing if and how the specific optoacoustic approach by Icthera could be used in lymphedema. This led to a rapid preclinical proof of concept study in mice, followed by an initial clinical study on lymphedema patients, resulting in the innovative work published in March in the Journal of Clinical Medicine. So I'll now let Guido explain the work. So over to you, Guido, and thank you very much for the talk today.
So good afternoon, and sorry for the delay again. Thank you very much for the introduction. So I will talk about lymphedema today and a new device. I work in Mechelen in Belgium, and I run a centrum of lymphatic surgery, and I also treat the patient conservatively. And what's important also to say is lymphedema is everywhere in the world. There are more than 200 million people worldwide, primary lymphedema, and also secondary lymphedema after oncological treatment of surgery. And what happens in lymphedema? The lymphatic fluid is prevented from draining to the venous system, leading to swelling of the limbs or to other parts of the body. So you have in this patient high risk of recurrent bacterial infection with worsening of the lymphatic damage. How do we treat this problem? Mostly I treat this problem with lymphovenous anastomosis. What is it and how does it work? So lymphovenous anastomosis is a connection between a lymphatic vessel and a vein, and this allows us to drainage the lymphatic fluid to the venous system. So we recreate a physiologic bypass that normally happens in the body. Now, how does it take place? We do some incisions, very small, of 2 or 3 centimeters, under local regional anesthesia. It's called Supermicro surgery, and it's really minimal invasive. So in order to perform this surgery, identifying the suitable vessel is really crucial. I would like to remember many of the teachers, like Professor Campisi, Professor Koshima, especially in this kind of technique of Professor Baumeister and many others that really helped us to perfectionate this technique. So you can see a micro picture with a microscope of an LVA, and you can see in this case that you have on the left side lymphatic vessel, and on the right side the vein. They are joined together with very small stitches, and you can see the small diameter. So how do we find lymphatics within the body with the incision? When we make the incision, the microscope is a device that performs ECG lymphography, and you can visualize the lymphatics as they become fluorescent under this light. When do we perform this operation? When we have no satisfactory results with conservative treatment, so manual lymph drainage, compression, stocking, so on. And with which patient? Primary and secondary lymphedema patient in between brackets common locations, arms or legs, or uncommon location like scrotum, breast, hip, and in patients with lymphocylia or in patients with lymphatic leakage. Now, which is the gold standard? Which investigation do you perform prior to lymphatic surgery? Lymphcintigraphy, that is absolutely the gold standard. One of the most famous doctor that started this technique is Professor Bourgeois, is known all over the world. So this in the beginning was not associated to SPECT-CT. Now it's Professor Bourgeois associated very often to SPECT-CT. We all learn from him. And there is not so much information about the small venous system. But you can have in this way a rough localizations of the lymphatics. Further, ECG lymphography, this is a technique developed from Professor Koshima in Japan, in Tokyo University, where it's injected ECG, intradermal or subcutaneous, depends from the operator, and then this fluid is absorbed and taken away from lymphatics. We can visualize this fluid because it's fluorescent. We can use a camera. It was first developed in Japan. And then we can mark these lymphatics on the skin. Further, we developed in 2017 a new way to find these lymphatics, and it was also published. And it was a very special device, ultrasound, but it's a ultra high frequency ultrasound, where the probe was 70 megahertz. And we could detect very small lymphatic without injection of contrast agent. Also interesting to say, you can find lymphatics with a very good ultrasound, even if it's not ultra high frequency. But of course, with this machine, we could find many more lymphatics and with much smaller diameter. Also, we can go to the next slide also, please. So this is very interesting because it's a famous video where you can see the lymphatic contracting, filling up first with lymphatic fluid, and then now you can see the contraction. So we could demonstrate with this machine that we could see the lymphatic contracting. So what is about now? Are we happy with this mean of investigations? What about the ECG lymphography? Yes, of course, we can trace lymphatics. It's very exciting. It's a great discovery from the Japanese. But I think it's an inadequate device because very often patients with lymphedema, they have dermal backflow. So I still use a lot this device, but when you have extended dermal backflow, you lose the signal coming from lymphatics. Also, you cannot detect deep lymphatic vessels, and you cannot visualize veins. About the ultrasound, you can detect very small lymphatic vessels. Time-consuming. You have to learn. There is a learning curve to get to a very good knowledge, and you miss the 3D spatial information about lymphatic and the vein because it's it's only in one plane, and this device has a depth limitation. So we're satisfied. Should we stop to what we have? We went on, and we started using the multispectral optoacoustic tomography, MSOT, in the preoperative imaging. I thought we could find more easily and more clearly lymphatics in with the use of a contrast of ECG. So as you can see from the image, with the MSOT, you project short laser pulses of near infrared, and these come out from the handheld probe. These pulses are shined to the skin, they go deep, and they absorb from tissue chromophores, for example, hemoglobin, for example, injected ECG. So, thanks to the optoacoustic effect that was already discovered in the 1880s, the chromophore released heat, which generates ultrasound pressure waves. So these ultrasound waves can be detected by the handheld probe and used for image reconstruction. It sounds very complicated, but it really works. So each light pulse produces a single wavelength that is a reconstructed image. So when you combine all these images acquired at multiple wavelengths, it's possible, thanks to the spectral unmixing, to assign to each chromophore present in the tissue a specific signal. So that means a color. So when you see ECG, you label with green and hemoglobin in red. And this is what it was done. So you have in real time on your screen immediately the color green and red of the different chromophores. So an optoacoustic device detects ultrasound, and this is a very important concept, and it's different from the ECG lymphography, because the ECG lymphography detects photons, and there is a limitation due to the light scattering from the tissue. So you cannot go deeper than 1 centimeter. And this is the big advantage of the MSOT capability, because you use ultrasound. So the next slide, please. So this was our setting. On the left, ECG lymphography. The Amamatsu machine on the right side, we had the MSOT Acuity Echo research system. The next slide, please. So we started this study. What for? We wanted to evaluate if the MSOT could offer benefits over the ECG lymphography in primary and secondary lymphedema, imaging areas of dermal backflow, imaging at a deeper level, and the accuracy of mapping of lymphatic vessels on the skin prior to surgery together with the veins. And we wanted to use an easy system and handheld system that we could usually at the bed of the patient. So we had 11 participants with primary and secondary lymphedema, also with advanced lymphedema. So as Tim said, this was published, and I would go to the next slide. In this patient, you can see a lymphedema of the arm that is really very pronounced. So when we inject ECG and we go to analyze the image coming out, the ECG lymphography only shows a dermal backflow. So this stops all the signal coming from the lymphatics under the skin because of the dermal backflow. And this is the big limitation in patients with severe lymphedema. When we use the MSOT, this is what you can see real time. So you can identify lymphatics. In this case, the ECG is marked in yellow and the hemoglobin in blue. And there is no need for further post-processing. This is real time what you get. So yes, next slide, please. So this is how we mark before surgery a patient. This patient could not be investigated with ECG lymphography because of the extended dermal backflow. The MSOT visualized the ECG labeled lymphatic vessel in the area of dermal backflow. So we could see through this mist, so through this shield of fluorescence on the top. And we could also visualize the vein, very important. You can see also on the plane XZ, the depth of the vein and of the lymphatic. And we could also visualize, and that's very useful for the surgeon, a 3D volume video where you can really see rotating the different relation in a 3D way of the vein and of the lymphatic. Also very interesting, we could identify, like we did before, we showed in the article of the ultrasound, ultra high frequency, that the vein collapses with pressure. So if you push with your probe on top of the skin, the first vessel that will collapse is the vein. And in this way, you can make a difference between vein and artery. The lymphatic, you will see, will not collapse, and the vein will collapse. So when you release the probe again, the vein will fill up full of red fluid, that is blood. And sometimes you can see green, and that's only an artifact, because when you stop the movement, you can always see the difference very clear between the hemoglobin and the vein. The hemoglobin in the vein. Further, there was, of course, a problem about the localization. So this device, the MSOT, was made, but we had, in fact, to adapt to use it to mark on the skin the position of the lymphatic and of the vein, and in order to mark the line of incision. So in one night, we had to build this special adapter. I printed at home with my 3D printer. And this adapter is designed to fit perfectly the 3D probe of the MSOT with a unique orientation to correlate with high accuracy of the image on the screen with the location on the skin. So what does it mean? That you have a line that says, please cut here, and then you can find under the line what you have been visualizing prior to surgery. So, in fact, on the next slide, you can see that the first image on the left shows the preoperative findings of the MSOT. Then this information is reported on the skin through the 3D printed adapter. And when you make the incision, you can find the same. The vein on the top, so it correlates with the red image, in the vessel in red on the first image, and the vessel on the bottom that is a lymphatic. And we could also demonstrate with ECG lymphography intraoperative that is mounted on the microscope that the second vessel on the bottom is really lymphatic because there is fluorescence inside. And that's also confirmation of the genuinity of the information given from the MSOT. Now I want to show you a tracing of a lymphatic in real time on the MSOT. So the video on the left side shows the operator tracing a lymphatic in the upper leg of a lymphedema patient. We can see the lymphatic crossing various blood vessels along its way. Now, for example, you see on the left side there is a blood vessel, it's in red. And the ECG, a mixed signal, is normally assigned to lymphatics, but may also be artifactly assigned to blood vessels during 3D detection movement. As soon as you stop the moving the detector, then this artifact will disappear. So you know always which is the lymphatic and which is the vein. Also very important, on the image on your right side, we could determine that the depth of the lymphatic vessel was at 17 millimeters on the XZ plane. Okay, next slide, please. So here you see the XY stitched image along the forearm of a patient. On the top image, there is no ECG signal that can be detected in accordance with the fact that this arm was not injected with ECG. It's a negative control. And on the bottom image, you can see several ECG lymphatics. So there are lymphatics filled in with the chromophore, that is the ECG, that are running along the red labeled blood vessel. So additionally, I also have to remember that the injected limbs were also imaged by MSOT prior to ECG injection as a further negative control, showing no ECG signal as we expected. The sausage-like appearance is due to the fact that the lymphangiome is filled in with ECG in the central part, and at the end where there are the valves, there is less ECG, and that's why we have this segmented appearance of the lymphatic. With the next slide, we can show the lymphatic inaction, like we demonstrated before, also with the use of ultra high frequency. So you can see the contraction of the lymphatic vessel ejecting the ECG, and afterwards the filling again of the lymphatic vessel. And I think this is quite interesting to see live happening. Next slide is about the importance of MSOT in primary lymphedema. So when we injected ECG in a patient with primary lymphedema on the foot, first image on the left, we had a view of dermal backflow on ECG lymphography. So we had no information at all. Where are the lymphatic? You cannot see them because the light coming from the dermal backflow is obscuring them. But when we went to analyze this picture with MSOT as XY image, not only we could find the lymphatic, but we could also find the vein on top of it at the same time. And that's the point that you can see on the skin marked with an X. So, which are our conclusions? MSOT is a patient-friendly imaging technique to detect lymphatic vessels in primary secondary lymphedema. Lymphatic vessels are detected in limbs even in areas not accessible by ECG lymphography. And also, MSOT is detecting lymphatic vessels as genuine, as confirmed also from ultrasound and surgery. With the MSOT, you can visualize at the same time lymphatic vessel and blood vessel. We can differentiate also the blood vessel from veins and arteries. And everything can be visualized with a high spatial resolution in one single examination. The information that we receive are real time, so there is no post-processing needed. And the 3D handheld probe allows for bedside examination, so it's very easy. I personally think that MSOT is the next step in all the examination that exists now, and is a promising tool not only in the preoperative assessment of patients with lymphedema, but also in studying patients with primary lymphedema, for example. Thank you very much. I don't know, maybe now we can go to acknowledgements. So thank you very much to our colleagues, Dr. Florence Belva, Dr. Takumi Yamamoto, and Dr. Ayashi Akitazo. And also thank you for the help that we received in putting together this study from Aetera Medical, and for sure thank you to Dr. Sardella that did also a tremendous job organizing all this, and of course also to the other staff of Aetera. I don't know if there are other questions about this.
So thank you very much, Guido. That was an excellent talk and some excellent imaging. We have had a number of questions come in. I'll just remind people they can type questions and we'll try to get through them as we go through the question panel. But as that's happening, I'll start with what we have now. First question, kind of an obvious one, is what are the advantages of optoacoustic imaging in finding the optimal LVA site over the imaging modalities currently in use?
Well, as I explained, first of all, when you analyze lymphedema patients, lymphatics are sometimes deeper than what you can see with ECG lymphography. Very often it's a severe lymphedema, so you have dermal backflow, and that gives, for me, a big limitation. And I always wanted to overcome that. And also, what is extremely important, with one examination, you can find lymphatic and veins, and you can see where they get very close, and you can have an idea which is the best point to perform. So if you would look now and how are our patients prepared before lymphatic surgery, first you have to do ECG lymphography, and then afterwards with ultrasound. And I think in this way you can save time. You don't do two different examinations and then trying to put together the information. You can see everything in one real-time examination. I don't know if this gives an idea of the improvement of this device.
I think that's a good answer. Regarding limitations of MSOT, were there any problems accessing all body areas, or were some body areas more difficult than others to image?
Well, we tested this in arms and limbs. We have often other. We also operated other parts of the body with lymphedema. I don't know. Maybe what I can think as a limitation could be maybe in the face. If you get close to the eyes of the patient, there you cannot. I would maybe not use it since it's a laser. I don't know how dangerous can it be. We always give protection to the eyes of the patient, but maybe that could be a limitation if you do a lot of lymphatic surgery in the face. But
yeah,
for the rest, I don't see many other limitations.
Yeah, I would point out, just because the question has come in, is that the MSOT device does use a laser, so both the subject and the operator need to wear safety goggles. Quite a few questions regarding ICG. Is the depth of visualization with MSOT much greater than with ICG optical imaging?
Well, I think yes, and there was also one of, I don't remember. I don't know if you remember the slide where I was showing the lymphatic that we were following in the upper leg. I don't know if Thomas can project it. So it's slide number 31, I suppose. So if you look at this, you can see. So in this lady, this patient, we could not see the lymphatic. It was too deep with ECG lymphography. We lost the signal, so we could not follow anymore in the upper leg. Although I have the last generation of the ECG lymphography device, we could not see it anymore, and that's why we tried the MSOT, and with the MSOT we could follow it much farther than not with ECG. And you can see on the right, we went up to almost 2 millimeters of depth. That is not possible with ECG lymphography.
Some more questions about ICG. Obviously, is ICG safe to use?
Look, I think the Japanese started this technique, I think 15 years ago. Professor Koshima, all the group, all the big guys from Tokyo University, all these students, Dr. Yamamoto, Dr. Ayashi, and so on. I mean, you can. They all use it very extensively. In Japan, it's really extensively used. ECG is a very old product. Was discovered in 1959. We never experienced any problem. The only thing where you have to be aware is that this product contains iodium, so you could have an allergic reaction, and you should be aware and explain it very clearly to your patients. And for the rest, we never had any problem using ECG. I think we performed, I don't know, maybe almost 10,000 ECG lymphography I performed myself, and up until now I never experienced any problem.
Okay, a question regarding the dermal backflow is how is the injected ICG dye cleared post-imaging, and is there a kind of conflict with backflow? Does the ICG is the ICG retained in a particular region for a particular period of time?
Well, look, the big limitation that you have. Yes, Thomas is looking for the slide. Look at this patient, severe lymphedema, and I think this was a stadium 3, almost 4 of the classification of Campisi. When you inject ECG, where there are the little stars in violet, this is what you get. It's a diffuse dermal backflow, and this stops all the information coming from the depth. It's like when you drive by car and there is fog. You don't see anything. The obstacles are there, but you cannot see them. And that was the big frustration that I had with ECG lymphography, although I still use it. I mean, it's still a brilliant examination found from the Japanese, but that's a very annoying limitation. You cannot see through the dermal backflow, and that's really a pity. And also, if I have to say, because of you use photons and you have a scattering, you really lose the information, in my experience, after 1 centimeter of depth. And yeah, those are unfortunately the negative point that up until now nobody could solve. And often you have patients with severe lymphedema, and you need to perform surgery in order to save those lymphatics from sclerotizing completely, like Professor Koshima always demonstrated. So you need to find those lymphatics and to shunt them to a vein. and under the dermal backflow, you cannot find them. So I think that's a very big advantage.
Okay. Just out of interest, if you went back to the same patient the following day and imaged either with MSOT or optical, would you still see residual ICG around the region?
Yeah, with ECG, yes, you would see it. The clearance as a dermal backflow, yes, it stays there. You cannot. It will stay for some days. It will impede the vision of lymphatics under the skin. Yes.
Okay. I think another interesting question here is the imaging of lymphatics through MSOT seems to detect one vessel or possibly two, whereas we know that multiple lymphatics should run in that specific area. Do you select specific vessels somehow during imaging, or some particular vessels labeled and others not?
No, for example, when I was showing when we were following lymphatic vessel, we just started following the lymphatic. I think it's slide that we can show it again, maybe slide. Yes, lymphatic vessel tracy during manual lymphodrainage. Yes. So no, this is just a lymphatic that we find accidentally. So you inject ECG and then you start a bit looking around, and then you find the lymphatic and then you start following it, and then you have to follow up until you get a red signal. That's the saturated hemoglobin, and there you know, okay, that's a place where I can perform the LVA, and then you go on and you try to go farther, because I think you always have to have a reserve incision. If one doesn't work, if you open it and then you're not satisfied from the quality of the vessels, you should have another possible incision place where you can place it. But we were just following random some lymphatics, the lymphatics that would come out after injection. And also in the upper leg, we were trying to get as close as possible to the groin, and where there was also dermal backflow. That was a concept introduced from Dr. Takumi Yamamoto and his group, and Dr. Hayashi when they defined as best place to perform a shunt, the place under the region of stardust, of diffuse or dermal backflow, and of course the MSOT is the perfect device to do this. You don't get any interference from the surface. I don't
Brilliant.
know if this is...
No, I think that answers it really well. What is the lowest or the smallest vessel diameter that you could detect?
Well, it's difficult to say. Now we had to in this study we were really not focusing on the diameters. I think we should do another study about diameters, but I can tell that for example, in primary lymphedema, the initial lymphatics are extremely small, and there was also another slide about that. So I think this slide you can see. We never really measured, but the impression we had, they were extremely small vessels, and sometimes you see them also on ECG lymphography, especially when you don't get immediately this kind of annoying dermal backflow on top. You can see they are extremely small vessels. I'm talking about lymphatics like 0.15 or 0.25 2 millimeters, so 150, 100 micron or 200 micron. But what is very important, and that's important to say, that the MSOT doesn't find the lymphatics. It finds the ECG that is in the lymphatic. So the lymphatic must be filled with ECG, otherwise you cannot see it, of course.
Okay, I'll jump in and just answer one question here, which was, can we detect metastatic infiltration of the lymphatic system? And the answer to that is yes, obviously not addressed here, but there are publications which show the tracking of the sentinel lymph nodes using a similar technique with ICG, and also the detection of cancers such as melanoma in the lymph nodes themselves, and we'll send you those references. And I'll move on to one final question. Let me just pull this up here. In how many patients could you detect lymphatic vessels, or more importantly, were the patients that you couldn't detect lymphatic vessels?
Yeah, that's a very good question. In fact, we had to learn. We had very short time. We didn't know if it was working and how we had to do it. So we had some problems in 3 patients. And why? Because in one patient there was hair, so the hair has to be removed. So it was a man. He had a lot of hair, and this gives a lot of interference, and that was very. We didn't do it in the beginning. We didn't think of it, and although it was a suggestion of Dr. Sardella that he told me, but I didn't think of it. And I think you have to remove them, not shaving, as he said, but you have to epilate with a special cream, and because the hair is black, and that will give a lot of interference. And other ones where unfortunately we could not find the lymphatics, I think because we didn't have in the beginning the right concentration of ECG, and you have to use the same concentration as the Japanese use. And that's and we corrected immediately, and in fact after that we had no problem. Always be aware that the lymphatic, you will not detect a sclerotic lymphatic. You will only be able to detect a lymphatic that is filled in with ECG. So that's also very important. But it gives you also another information that what you can detect is working, is vital. So you can use that lymphatic to make an anastomosis with that.
Okay, and I'm going to ask just one more question. One's just come in, and an interesting one, I think, is what criteria defines a high quality lymphatic for LVA?
Well, I think you have to use to act as fast as possible. Unfortunately, this is not the case because it doesn't depend from us. It depends only when they ask you to see the patient. You should use lymphatics where the contractility is not lost, and there is no hypertrophy of the wall of the lymphatics, so that you have a good lymphatic that is contractile, that is not where the lumen is not just a pinhole. And so I think even in this case, the MSOT can give you a good information as well as also the ECG of the ultrasound. So you really have to have a good lumen. That means also that you don't have such an hypertrophy and degeneration of the wall. but it's in general a concept that you can translate from vascular surgery. I'm a vascular surgeon, so when it's good to make an anastomosis of a vein when it's not calcified, when it's not hypertrophic, when it's still, let's say, damaged but still young enough that the anastomosis that you perform will last in the time.
Brilliant. So I'm going to leave it there as we're coming up to the hour. Thank you very much, Guido, for both the presentation and taking such time with the questions. I'll also say thank you to Thomas Sardella, my colleague, for operating the slides, and a big thank you to everybody who attended today. As mentioned, we recorded the webinar and we'll send you a copy and also address some additional questions over the next couple of days. So thank you very much. As we move towards the weekend, then have a lovely weekend. And once again, thank you, Guido, and I hope to see you soon.
Thank you very much. And I hope it was interesting, and still a good afternoon from me, and thanks for listening to my presentation. Good evening.